Okay, so when we talk about pneumothorax, basically we are talking about now presence of air in the pleural space, which is going to cause partial or complete collapse of the lungs because of the loss of that negative interpleural pressure. So there is that loss of that negative interpleural pressure. As a result of that loss, now the lungs get to collapse. And of course, with the collapse of the lungs, and we'll be looking at the various types of pneumothorax, then of course, we get to see that patient presenting, of course, clinically, we'll get to see what you've discussed previously with what happens with the collapse of the lungs. So we have various types of pneumothorax. We have what referred to as the spontaneous pneumothorax. Usually, this occurs with trauma, or without trauma. And with spontaneous pneumothorax, of course, we have what we refer to as the primary spontaneous, secondary spontaneous pneumothorax. They come in as a result of the rupture of a bleb. A bleb here now we're talking about an area of the lung that is weakened. And because of that weakening, now and the rupturing of that particular area, then air gets to move from the lungs to the intrapleural space, and that's going to cause the rupture of the lungs. So like I said, there'll be this primary spontaneous pneumothorax, there is secondary spontaneous pneumothorax. Usually primary spontaneous now happens in people without underlying lung disease. So the rupture just happens without really any underlying disease. Then the secondary spontaneous pneumothorax, because there's an underlying lung disease, like in cases of COPD, in cases of tuberculosis, asthma, lung cancer, they can lead to the collapse of the lungs. Then we have the open pneumothorax, the closed pneumothorax. The open pneumothorax, which comes in as a result now of an opening creating through the chest wall, and it's going to allow now air to flow between the pleural space and the outside of the body. Like in cases of lacerations, like a stab wound, one has been stabbed around the chest wall, and as a result of the stab, now air gets in from the outside of the body into the pleural space, and that causes now a shift in that negative pressure, and that leads to now the collapse of the lungs. Then we have closed pneumothorax. Closed pneumothorax, which is which again occurs when air gets into the pleural space. Yes, closed pneumothorax, when now air gets into the pleural space from within the lung, and that's going to increase pleural pressure and prevent lung expansion during inspiration. Sometimes this is referred to as traumatic pneumothorax, like in case of blunt chest trauma, which ruptures the lung tissue or which causes the lung tissue to rupture. And because of that rupture now, it results in air leaking into the pleural space. So again, that's going to result in collapse of the lung, because now air is getting to find its way into the pleural space. Then we have tension pneumothorax, which results now from build-up of air in the pleural space, because now it has been trapped there and cannot be able to escape. Now, tension pneumothorax can develop either from spontaneous or traumatic pneumothorax. So again, because of be it spontaneous or traumatic, air has got in, but now it has been trapped within the pleural space, or it has built up within the pleural space, and as such, again, affects now or leads to collapse of the lungs. Again, of course, with the entry of air and it's been trapped into the pleural space, again, it increases that intrathoracic pressure, and that can lead to compression of the lungs, can lead to compression of the heart and the major blood vessels. Part of it, again, which we talked about yesterday, in the morning, remember we talked about pulmonary hypertension. That again can lead to that. It can also lead to reduced venous return because of now the compression of the major blood vessels as a result of the increasing intrathoracic pressure. Hemothorax, um, again, hemo from blood, so blood accumulating in the pleural space, more especially when rip lacerates the lung tissue or the intercostal artery, that compresses the lungs, gets to limit the respiratory capacity, and mostly now with the hemothorax, maybe could be as a result of rupture of a large or small pulmonary vessel, and now the blood that is oozing from that gets now to accumulate within the pleural space. We have the hydrothorax, which is now fluid accumulating in the pleural cavity. So your signs and symptoms, of course, there's the general symptoms like the anxiety, the asymmetrical chest expansion, so it's not uniform in terms of the expansion. We have diaphoresis, we have dyspnea, there is dullness on chest percussion, more especially in hemothorax and tension in pneumothorax. We have hypotension in hemothorax because of the blood loss into the pleural cavity, sharp chest pain, which increases with exertion, tachycardia, uh, uh, the tracheal shift or tracheal deviation, which is a late sign, more especially in tension pneumothorax. We can see distended neck veins in cases now the intrathoracic pressure increase, which has affected major blood vessels. So you will always see that, like in the pulmonary hypertension we talked about. Cyanosis will come in. Shock, you can expect to see like things like hypovolemic shock in this case. Diminished or absent breath sounds can also be seen in a patient with the pneumothorax. Then we have diagnostic findings. You can do chest X-ray. Chest X-ray will of course confirm the diagnosis. You'll always see a visible collapsed lung because pneumothorax is about now the lungs collapsing. So you'll see a visible collapsed lung. You will see air in the pleural space. Then you'll see the mediastinal shift. In mostly can be seen in tension pneumothorax. We can do the ABG, the arterial blood gas, which can show you hyposemia, that is the respiratory acidosis and the hyposemia. Can be seen that. Pulse oximetry, which will show you decreased oxygen saturation levels, which sometimes again can normalize within about 24 hours. You can do an ultrasound, which is common, more especially in cases of trauma. You can do a CT scan when now the chest X-ray is not so clear in terms of giving you a diagnosis. Your management, bed rest should be encouraged for the patient. Active range of motion exercises with the affected arm, and any of the arm that's affected. Blood transfusions in hemothorax can be indicated. Chest tube to water seal drainage for tension pneumothorax to remove the excess air and excess fluids. Negative pressure should be, of course, returned to the pleural space by now inserting the chest tubes that are attached to the underwater drainage. Incentive spirometry, which will of course be used now for to assist with lung expansion. Occlusive dressing for open pneumothorax. So that's going to prevent now outside air getting into the pleural space. We have oxygen therapy, of course, in cases now of where the patient oxygen saturation levels are going down or patient presenting with cyanosis. Management, drug therapy, analgesics, morphine, and also you can give antibiotics prophylactically to minimize patient uh, getting infections, more especially where you have things like the open stab wounds being the cause of the pneumothorax or the collapse or causing the collapse of the lungs. Your nursing management assessment, of course, auscultate the lung fields. Chest percussion. On chest percussion for pneumothorax, you will hear the hyperresonance. Chest motion during inhalation. We said that there is, of course, on your clinical manifestation, where we've talked about, of course, now the asymmetrical chest expansion. So you get to check for that. Paradoxical chest movements, again, as a result of the collapsed lungs. Skin for changes in color, cyanosis, you want to evaluate that. You are now saying diagnosis, you can have so many: infective breathing pattern, impaired gas exchange, infective airway clearance, acute pain. All these are possible nursing diagnosis you can get to see in your patient. Your interventions, monitor, record vital signs. We've already seen the vital signs kinks, because now, more especially with the presence of kinks, there'll be a sudden reduction in the drainage. So you got to check for that. Cardiovascular status, administer oxygen, respiratory distress, more especially in hypoxemia. Patient in high Fowler's position should be placed there. That is going to enhance chest expansion. Any question to that point? Manage pain, of course. Educate the patient to avoid strenuous activities, very important, because again, you don't want to aggravate the problem. So, of course, prognosis can be good, more especially with intervention. Can only worsen if there are underlying conditions like the COPD and underlying lung diseases. Any question?
I'm asking, what is it that is making the tension type of pneumothorax to be more life-threatening as compared to the other types of pneumothorax?
Okay. What is that makes tension pneumothorax to be more life-threatening compared to the others? Okay. So yeah, the types of pneumothorax you're talking about, tension pneumothorax is life-threatening. Why? Because now, like we said, from our definition of tension pneumothorax, there is trapping of air once it enters the pleural space, and it cannot be able to escape. With the trapping of air within the pleural space, then progressively it increases the intrathoracic pressure. Remember, I said that once the air is trapped there, it increases intrathoracic pressure. And once intrathoracic pressure increases, then that increased intrathoracic pressure gets to compress the lungs. gets to compress the heart and the great blood vessels, like I mentioned. And with their compressed lungs, compressed heart, and blood vessels, it can now lead to severe respiratory distress. It can cause reduced venous return. It can lead to hypotension, and it can lead to other things like the obstructive shock. So that's why it needs emergent or urgent intervention just to decompress uh, these organs that have been affected, because you can imagine where you have a situation where now there is severe respiratory distress, there is reduced venous return, hypotension, shock, then you have potentially a patient going now into multi-organ failure and death.